The screen visible?
Yes, sir.
Okay. So this whole topic is coming under the depth of anesthesia and awareness. So anesthesia is a combination of hypnosis, analgesia, and of course muscle relaxation. So this is called the balanced anesthesia technique, where we use this combination, and the response to a painful or noxious stimuli can happen in the form of a somatic response or an autonomic response. Okay? So somatic response can be either sensory or motor, and autonomic response can be the form of respiratory changes if the patient is breathing normally without paralysis, or it can be the form of hemodynamic changes, or it can be in the form of hemodynamic or hormonal changes. Now, these are all the afferent and efferent pathways of this response, and these are all the modified scales which were used to find out the responsiveness. And this is the Bryce questionnaire which was used to identify or ask the patient after a general anesthesia to see whether they had any awareness. So these are the questions that were asked. What was the last thing you remember? What was the first thing you remembered on waking? Do you remember anything between going to sleep and waking up? While you were sleeping during the operation, did you dream or did you hear any voices? All these questions can be asked. Now, the stages of awareness, they are divided into these 4 stages: conscious awareness with explicit recall, conscious awareness but no recall, no explicit recall, subconscious awareness with implicit recall, and no awareness or recall. That means this is a correct depth of anesthesia. So these are called the stages of awareness. And there is another person, White, who suggested that anesthesia is a continuous process. It is a continuum. So no absolute unit of anesthetic depth to mark progress along the continuum can be happening. So that is what he opined. And the risk factors for this are normal requirements may not be delivered. Sometimes low requirement, low delivery, high requirement, normal delivery. So these are the things which can result in this. Now, definition of awareness and memory. Awareness is post-op recall of events occurring during GA. That is the definition of awareness. If somebody is able to recall what has happened, even though you think they are all unconscious, that is the thing what is called awareness. Then there is another terminology called amnesic wakefulness, responsiveness during GA without post-operative recall. So intraoperatively they react in the form of sometimes they overcome the muscle relaxant effect, try to move the hand limb, or you can sometimes closely monitor the patient. You can see the forehead wrinkling can happen in some patients. When they feel the pain, when they are not they are intubated and you are ventilating them with a volatile, and the muscle relaxant effect is wearing off. At the time, you can see their forehead wrinkling because of the response as a response to the pain or intraoperative event. Sometimes they can have a dreaming effect, which may be confused as a recall or awareness. This is one thing that is confusing to the assessment of awareness. Then explicit memory, where the patient is able to tell exactly what has happened. And there is another thing called implicit memory, where experiences without any conscious recollection. They say, I think I heard something, I felt something, but they will not be able to reproduce it. Whereas in explicit memory, they will say, the surgeon took 10 bites on my abdomen, I was counting. I had a patient who could recall such things earlier in my career. He said, I could see 10 times he poked me on the abdomen to close my abdomen. I could feel the stitches happening. So that much of recall can be happening. So these are the terms that you have to keep remembering. And causes and risk factors of awareness are, it can be patient factors like sepsis patient, hyperthyroidism patients who require high doses and you are not given adequate doses, or patients who are chronic alcohol patients. They have ability to metabolize our drugs faster and they require higher doses. So unless you give the adequate dose, they can. I have had an experience of when the thiopentone days, after giving for 450 milligrams of thiopentone, knowing that the patient is an alcoholic, patients sat up after the completion of the injection. He simply would not go under at all. So then we have to force him down again on the table, give another up to 500 milligrams to come sedate him and make him unconscious. And the medications like beta blockers also will interact with that, and previous history of awareness are all factors called the patient factor. Anesthetic factors causing awareness are equipment malfunction, PIVA technique, where inadequate doses or correctly delivered doses are not given. And when difficult intubation cases, you fail to notice the time and the intravenous induction given wears out and patient becomes aware during your delay in intubation, and that is the time awareness can happen. And when you use neuromuscular blocking agents and simply paralyze the patient without adequate agents to produce or maintain unconsciousness, like enough MAC of volatile agents or continuation of intravenous induction agents, then the patient may have awareness because of the just a paralyzed state but not completely anesthetized. And the third surgical factors is the common causes are trauma surgery, where patient will be hemodynamically unstable and you don't want to give too much depth of anesthesia. This is where exactly the other category of patients who recall from the gave the diagnosis of awareness under anesthesia were trauma patients, because the anesthetist feared depressing the hemodynamic state system. So they gave very light anesthesia to maintain the patient's physical anesthetic state. And cardiac surgery, patients going on bypass and other things were not anesthetized in the earlier days properly. And cesarean under general anesthesia, this is where the exactly the identification was done. So assessment of the depth, subjective method and objective method. So you can see autonomic changes like tachycardia, hypertension, changes in pupil diameter, isolated forearm technique. And the objective methods, EEG derived indices, spontaneous surface electromyogram, lower esophageal contractility, heart rate variability, and evoked potentials. So this is the earlier simple technique of pulse respiration, sweating, and tears. And then later came the EEG monitoring using all these various gadgets. And isolated forearm technique and lower esophageal sphincter, auditory and the somatosensory evoked potentials were later on introduced to. These are all more research tools to establish the presence of awareness. So this is the person about whom I told you. He is called Mike Twinstall. He is a British Aberdeen anesthetist, born in 1928. He died in 2011. And he is the inventor of Entonox, which revolutionized the labor analgesia. And he also developed the isolated forearm technique, making it possible to detect the awareness during light general anesthesia. He also gave a drill called failed intubation drill, especially in obstetric patients. When you are not able to intubate the patient, you are putting both the mother and the fetus in danger by hypoxia. So he developed what is called a failed intubation drill. What to do to reduce the maternal deaths. He helped to create an anesthetic cream for children. That is something like EMLA cream was also introduced by this person. He and his colleagues also established one of the world's first neonatal intensive care units. Okay? So he is Mike Tunstall. And this algorithm interprets ECG. Now coming to the BIS and entropy, which are the short note questions or the questions that can come in your theory, it uses a dimensionless number. Commonly examination, they may ask you what are the other dimensionless number you use. Soundarya, can you give examples of other dimensionless numbers where there is no unit attached to that, like millimeters of mercury or centimeters, or does pH have any dimension? You say 7.35 to 7.45. Does it have any dimension?
No, sir.
Oh. Does Reynolds number have any dimension?
To 4,000. No, sir.
Reynolds number also has no dimensions. Okay. So the examples of dimensionless numbers used in anesthesia are Reynolds number and pH and this value. Okay. And the entropy values also. That also does not have a dimension. So the parameters used to these are the burst suppression, quasi suppression, relative. All these things are just for the knowledge, but in the exam you can just say it is based on the EEG modification or analysis of EEG by the three methods what she mentioned, but the Fournier analysis, and it gives the values from 0 to 100. 80 to 100 is supposed to be awake, 60 to 80 is slightly sleepy or drowsy, 40 to 60 is adequate correct depth of anesthesia, and 0 means no brain activity. So sometimes we can use this also for assessing brain death. So they are using not only for anesthesia monitoring, but also in brain death. This is considered as one of the method to establish the brain death by when you attach this, you get a 0 activity in the electrical activity. Okay. And this is how the leads are attached, and these are the various waves of EEG, which you have to remember: delta, theta, alpha, and beta with their frequency. And which one is the wave that you will have when you are fully awake?
Beta.
Beta, because you can see brain is very active, electrical spikes are there. So when you are fully awake, you will have beta. When you are sleeping mildly, you will have alpha. When you are theta, you are in a deep state of sleep. So based on that only, they identified the various states. And this is narcotrend. Now coming to entropy monitoring, the word entropy means it's a measure of irregularity in any signal. That is the meaning of the word entropy. The measure of irregularity in any signal. And during general anesthesia, EEG changes from irregular to more regular patterns when anesthesia depth becomes more and more. So from the hyper beta activity, what you saw in that earlier picture, it should become very slow waves like that, as though it is mimicking the normal sleep. So that is the reason why you should know these four varieties of EEG signals. And similarly, the fronto electromyography is also, that is where I told you, patient you can see wrinkling their forehead. So the frontalis muscle may be the muscle to act when the patient is in a lighter plane of anesthesia. So they started measuring the motor activity in the frontalis muscle also. So combining these two, you get the entropy monitoring. So entropy module measures these changes by quantifying the irregularity both in EEG as well as in frontalis electromyographic signals. So this is how the so you have to put the electrodes both on the forehead, in the central, and on the over the eye, and in the temporal region. This is how the correct placement should be done. And this is the entropy setup, monitoring the electrical activity of the brain and facial muscles with the entropy module. In adults, the values be shown to correlate with patient's anesthetic depth and state. High values indicate irregularity of the signal, that saying that patient is awake. Just like the beta wave that you saw in the earlier picture, it indicates that the patient is awake, and it will give a higher value. and a more regular signal produces low entropy values, which can be associated with possibility of lower consciousness. So this is how the grading is done. 100 is awake, and entropy, as she said, there are two states of entropy: response entropy and state entropy. So the state entropy measures different types of waves, and response entropy measures waves which are reacting to the stimulus. So that is what you have to understand by these two terminologies. And these things give the various, so what frequency they measure is given here. And you can see the state entropy value is 0 to 91 maximum. Whereas the response entropy, you have 0 to 100 because of the higher activity that's happening both in the EEG as well as in the frontalis muscle. And these are all the things that same thing given in verbal form. And entropy is sensitive to activation of facial muscles also. So entropy measures both the EEG and frontalis muscle, and response is very fast, within less than 2 seconds, and it is active during awake state, but also more active during surgery. It may also be activated during surgery if the patient is in a lighter plane of anesthesia. And facial muscles also give an early indication of emergence. That is, the patient's recovery from anesthesia is also shown by the facial muscle activity, which can be seen in liquid rise in the values of response entropy. So, state entropy values are always less than or equal to response entropy. And in general anesthesia, the hypnotic effect of certain anesthetic drugs on the brain may estimate the various values. And SC is less affected by sudden reactions to facial muscles because of the closeness of the EEG signals and the frontalis signals. And when we use the neuromuscular blocking agent, administered and surgically appropriate, they may affect the effects of the EMG. They may paralyze that also. So when you put an entropy monitor on the patient, these are all the steps that we have to go through, because this is not a commonly used monitor. I thought I will just give you the way how to use it in case you happen to come across this monitor. So as soon as you first place the electrodes on the patient's head in the proper position, the machine itself will do a check whether you have placed the electrodes in the proper position, and it will give a signal that sensor check passed. So all the 3 electrodes are in normal position, you will get this particular display. Then the second thing is, you will get a, during awake state, you get a very high value. Initially, before you start inducing the patient, this is the value you are supposed to get. You will get a maximum of 91 for state entropy and a response of 98 for response entropy. And then once the patient goes into the anesthesia, decrease in entropy measurement may enable the physician to observe the moment when the patient loses responsiveness. So gradually it goes down, goes to this level of 26 and 24, which means it is a very, very low depth, but quickly it comes back to the 48 and 41, where both entropies stabilize during the operation. So even though it may drastically go down during induction, it will not stay in that same place unless you keep on pumping more and more drugs. The induction agent will initially produce a very low value, but then it will start stabilizing at 48 and 41 during the surgery. And then these are all the displays that you will see. Burst suppression, if you select this mode, this will not be normally displayed initially. So you have to click the button to show this burst suppression ratio. Then it will indicate the amount of silent periods of raw EEG in that particular level. And then during recovery, when you just cut down all the anesthetic agents and then try to get back the patient to normalcy, you will find that again the values going up. So this is induction stage, this is recovery stage. So both the stages you will find the values have to come back to that. That gives you an idea that there is a complete recovery of the circular nervous system by using this. That is the advantage of entropy. And of course, these are all other monitors not connected to this particular question. And this is auditory evoked potential monitor. And the common question, MAC and awareness. So when you use minimum alveolar concentration of a anesthetic agent, there are different varieties of MAC or different values for MAC. What is MAC awake concentration is 1/3 to 1/4 of the MAC which is required for the surgical incision. And MAC amnesic is a similar value when used with other agents. So you can use two types of MAC, MAC induction or MAC maintenance, MAC awake, MAC amnesic. There are 4 different types of MAC values which you have to know about. Why depth of anesthesia monitoring is important? It helps to identify the sufficient suppression of response to noxious stimuli. It helps to titrate the dosage and minimize under or overdosage of drug. Reduces drug consumption cost and enables faster recovery. So it makes the anesthesia cost effective. You can, especially the volatile anesthetic agents are all very expensive. So you can cut them, cut the inhalation agents at the appropriate time so that the cost can be reduced. And it importantly reduces the post-traumatic stress disorder in patients and reduces the chances of litigation because patient, if they are awake, then they will try to sue the doctor saying that you have not given me adequate anesthesia and I was recalling everything. So these are the, I'm sorry, this is something else, not surprised. So that will be the answer for entropy and this monitoring. Okay.
Yes, sir. Yes, sir. Thank you, sir.
Presenting the next one.
Ashna.